Hi, my name is Raman Muthusamy. I'm the Director of Endoscopy for UCLA Health System, and I'm a clinical professor of medicine at the David Geffen School of Medicine at UCLA. And I'm here with my colleague, Dr. Stephen Kim, who is a clinical instructor at UCLA and is also a member of our interventional endoscopy faculty. And we're here to discuss Stephen's recent paper that's been accepted in gastrointestinal endoscopy entitled Risk Factors Associated with the Transmission of Carbapenem-Resistant Enterobacteriaceae via Contaminated Duodenoscopes. Stephen, maybe you could tell us a little bit about this issue. It's obviously received a lot of press, both in the scientific community as well as the lay press. Yes. Tell us how this issue was identified here at UCLA.
Sure. So a little over a year now, we had an outbreak of CRE. And our infection prevention team here at UCLA noticed that this infection occurred in patients who had undergone ERCP. And so they did a thorough investigation looking to see where this outbreak occurred from and where there could have been, where the source could have been. And they looked at our ERCP scopes, looked at our duodenoscopes, and found that the scopes had all been reprocessed correctly based on manufacturer and FDA guidelines. And so there didn't seem to be a fault there in the reprocessing of the scopes themselves. But then they cultured the scopes, and they found that the cultures were negative. And so the two duodenoscopes that they identified as a possible epidemiologic link were culture negative. So what they ended up doing was some specific microbiology testing where they found this molecular plasmid specific to the Klebsiella that was seen in these patients. And they were definitively able to identify that these patients who had undergone ERCP with these two duodenoscopes had the same exact bacteria that were infected. And so that's how we were able to identify the outbreak.
It's interesting you mentioned, Steve, that the cultures were negative and that you had to use this really sophisticated technology to really identify that the duodenoscope was the link. Yeah. What sort of ramifications has that had for endoscope reprocessing here at UCLA?
Sure. So the fact that the bacterial cultures were negative in our duodenoscopes is not, I'd say, uncommon. The thought process here is that there's an elevator channel in the duodenoscope that's difficult to access and difficult to clean, for that matter. And so if you're unable to access it during the cleaning process, you may not be able to access it during the swabbing or culturing process as well. And so the fact that our culture were negative likely represents the fact that we were unable to get the swab in the right place to culture the bacteria hiding in the elevator channel of the duodenoscope.
So tell us a little bit about how you got the idea for this study.
Yeah, I think the CRE outbreak that we had last year was unfortunate, but also at the same time, I think we had a professional and academic responsibility to try to learn from this experience. We felt this was a unique opportunity for us to look at potential clinical risk factors that would put certain patients at higher risk of getting infection as opposed to others when undergoing ERCP with a duodenoscope.
And tell us how you went about performing your study.
Yeah, so it was a retrospective study, and because we were able to identify the two duodenoscopes that were implicated in our outbreak, we basically went back and looked at every patient that were exposed to either of the two contaminated duodenoscopes. And we had this complete list, and so we were able to compare the patients who were infected versus those who were not.
And how did you determine whether they had transmission of CRE?
Yeah, so the CRE infected patients typically had some sort of positive culture. The patients who were colonized were found only after the fact. After the outbreak, we sent out rectal swabs to patients who were exposed, and a small number of patients were found to be colonized, but otherwise asymptomatic. And then there was the other larger group of patients who underwent an ERCP with a contaminated duodenoscope, yet never gotten an infection.
So you essentially found all the potential affected patients, tried to get rectal cultures on as many of them as you could, and then compared the results of those who were negative to those who were positive or clinically.
That's right. Okay. So my study design is basically a retrospective study. 115 patients were found to be exposed to either of the two duodenoscopes. And what we found was that 15 patients were ultimately infected, 8 of which were actively infected, requiring urgent treatment. And then there were 7 patients who were only colonized, but otherwise asymptomatic. And so we compared the 15 patients who were 15 patients who were infected with the other patients who were not.
So what factors did you look at to compare between these patients?
Yeah, so we looked at all the typical things like patient demographics, age, sex. We also looked at indications for ERCP, the number of ERCPs performed, the duration of the ERCPs, as well as technical factors that were performed during the time of the ERCP. So things like biliary stent placement, cholangioscopy, symptotomy, stone removal, to see if there were any of these factors that may have played a role.
And so what did you find?
Yeah, so in our final results, we basically found that there were 3 independent risk factors that put patients at higher risk of transmitting CRE. Those 3 risk factors were biliary stent placement, a diagnosis of cholangiocarcinoma, and being an inpatient at the time of the ERCP.
So procedure time and things like contrast injection and a variety of other things, you looked at those things and they didn't seem to play a role?
That's right. So we didn't find any other independent risk factors. The only other risk factor we were able to identify was prior antibiotic exposure, but when we controlled for cholangiocarcinoma, that variable ended up falling out. And so we were left with the 3 independent variables that I discussed earlier.
Were you surprised by these findings?
I'd say in hindsight, probably not. The fact that we know that the elevator channel of the duodenoscope is the likely cause of our inability to adequately reprocess these scopes. I think biliary stent placement makes biologic plausible sense. You take a plastic stent, you pass it through the elevator channel, you place it in the bile duct, it sits there for a while. I think it makes sense that these patients are at higher risk of getting CRE. Cholangiocarcinoma patients have obstructing tumors that lead to biliary stasis. And so you can imagine you do an ERCP, they may get a small amount of bacteria into the bile duct, and then because of the obstructing tumor, that bacteria can sit there and grow, leading to an infection.
So Steve, how can our colleagues use the information that you've learned from the study?
Right. So I think the independent risk factors that we were able to identify are important for prioritizing or identifying patients who are at higher risk. So in the event that an institution has a CRE infection and they're wondering, is this related to duodenoscopes or not? I think you look at these patients first. Patients who had undergone ERCP, who had biliary stent placed, or have a cholangiocarcinoma diagnosis, these patients are the ones that the infection control team should be going after to identify, these are the highest risk patients, did they get CRE, and if so, is it related to the ERCP procedure or not? And I think that's where it's most important.
So, I think this continues to be an ongoing area of research and discovery. I think that we've now realized that this has occurred more often than we originally appreciated. There are now reports of at least 25 institutions and potentially as many as 350 patients that have been affected worldwide. And in particular, I think this will be useful information for those who are using an intermittent culturing surveillance program as you described. So thank you very much, Steve, for sharing your results with us.
Thank you very much.